So, for management of CAR T cell therapy related neurotoxicity and multiple myeloma, it's a dynamic field and one where we're learning kind of as we go about some of the more nuanced characteristics. I'm Peter Forsberg from the Colorado Blood Cancer Institute. And, in multiple myeloma, we now have two approved CAR T cell therapies, cilta-cel and ida-cel. Both ida-cel and cilta-cel can have associated immune effector cell associated neurotoxicity syndrome, or ICANS. That's a relatively common neurologic toxicity that occurs across all CAR T cell constructs, both those that are approved for the treatment of multiple myeloma as well as for the treatment of lymphoma. Both happen in our myeloma constructs at a relatively low rate. And the approach for management of ICANS is relatively well defined. The management leans on immunosuppressive modalities, including corticosteroids. And then beyond corticosteroids, we sometimes have to use additional immunosuppressive agents to try to reverse, ICANS when it happens in the early post-CAR period. ICANS, happens at a relatively low rate with both cilta-cel and ida-cel in comparison to some other CAR T constructs. We've found those to be relatively manageable neurologic toxicities with both our approved CAR T constructs for multiple myeloma. In myeloma, there has been some complexity with neurological toxicities associated with CAR Ts, in particular because with cilta-cel, which is currently the more commonly used CAR T cell product for multiple myeloma in the relapsed and refractory setting, there are occasionally atypical or non-ICANS neurotoxicity events which can happen in patients. We've seen these both in clinical trials as well as in routine clinical practice. And the spectrum of non-ICANS neurologic toxicities that may develop following cilta-cel in particular is somewhat diverse. So as opposed to ICANS, which happens in the relatively early post-CAR setting and is pretty well defined both in terms of its event rates and its characteristics, non-ICANS neurologic toxicities may be a little bit less consistent in when they develop, and they can be more diverse in terms of both the manifestation and potentially the mechanism of how those events occur. So with those in the myeloma community, we've had to work to identify, and come up with management strategies in a more diverse real-world setting. That's something we've been working on very actively in the myeloma community. And it is one thing where it's been pretty exciting to be part of the myeloma community because there's a real sense of collaboration of trying to identify and innovate on how we might identify risk, identify events, and then develop strategies to treat these events. Some, may be more straightforward in their treatment than others. That would include things like cranial nerve palsies, which do happen in a percentage of patients after cilta-cel. These tend to be reversible events, and the management leans on corticosteroids, IVIG, and people have tried some additional potential approaches. With some of our other non-ICANS neurotoxicities, the management has been more challenging, with things like movement and neurocognitive toxicities following cilta-cel, which we've known happen in a small percentage of patients since the earliest CARTITUDE-1 trial data was presented. These are less reversible events, and they are potentially harder to treat. So people have been trying to come up with treatment strategies in real clinical practice. People have presented data on modalities like cyclophosphamide or intrathecal methotrexate as potential approaches to try to reverse symptoms after initial onset. Early identification is important. People are identifying new potential contributors, and from there we're working kind of actively on trying to identify approaches. One thing we have found that seems to predict the risk for developing atypical or non-ICANS neurotoxicities with cilta-cel may be really substantial lymphocyte expansion. When we put our T cells in to patients, they start by sort of moving into the bloodstream and then eventually attaching to their target, which is BCMA and myeloma currently, and then eventually expanding as a result of activation. This actually happens a little bit after the common CAR T associated toxicities that we see, both classical ICANS as well as CRS. So a few days after the window when that's most likely to happen, we actually see a fairly consistent increase in what's called the absolute lymphocyte count, which is, in this setting, a fairly good surrogate for the CAR T cells growing. And we have identified in our patients, and this has also been described by some groups, including the Mayo Clinic team, that patients who have a more substantial lymphocyte expansion, who go above a sort of a normal lymphocyte range into beyond normal range, may be at increased risk for subsequent neurologic toxicities. So that's a real area of interest in terms of exploring approaches. Maybe it's something where we can identify patients who are at risk for neurologic toxicities and intervene earlier. At CBCI, we've developed an approach to use dexamethasone in those patients who have an expansion. This is kind of still an exploratory approach, but it is one that we think may be making a difference in terms of reducing the potential or the severity of neurologic toxicities. And that's something that's now being looked at, hopefully, in the near future in more prospective trials that will hopefully have a little bit more robustness in terms of the investigational approach. But I think that I think it is something where we're learning as we go. And I do think we're making progress in terms of identifying patients at risk, in terms of maybe taking steps before the CAR T cell is administered to reduce risk. And then in terms of coming up with some initial modalities to deal with, maybe to prevent, hopefully, but if not, to sort of deal with non-ICANS neurotoxicity as it presents itself and as it emerges. So, a really important area of inquiry and of investigation in the world of multiple myeloma currently, as CAR T therapy becomes an even more important modality for us in the relapse setting. And one that I think we're seeing a lot of emphasis across many different centers and groups to try to innovate with approaches, and something that I'm pretty convinced we're going to make really significant progress with in the near future. And hopefully we already have some of the indicators for who we might need to intervene on to sort of prevent, as opposed to just treating these things once they've developed.